Good morning and good afternoon and good evening, everyone. We are going to go ahead and get started. This is the second day of the virtual technical consultation on contraceptive-induced menstrual changes. My name is Kate Rademacher, and I'm a Senior Technical Advisor at FHI 360. We are really, truly delighted to be joining for part 2 of this 2-part meeting. Yesterday was fabulous and just really appreciated all of the discussion and information and exchange. And we're looking forward to diving into part 2 of this important discussion. This meeting has been co-organized through the Envision FP and Research for Scalable Solutions projects, both of which are funded by USAID. Next slide, please. So I just want to go over a few housekeeping items before we dive into our rich and full agenda. I'd like to encourage folks to just take a moment to introduce yourselves in the chat, including your name and where you're dialing in from, including the country if possible. Please keep yourself muted during the meeting, and we encourage you to insert comments or questions at the chat bar at any point. Also, one thing that we really took away from yesterday is there's just so much rich discussion and questions on this topic, and we won't be able to address all of the comments and questions. We are going to develop a written Q&A after the meeting that will be posted online, so if your question is not addressed during the session, we'll be sure to address it after the meeting. Also, I just wanted to encourage you to share information about this meeting as well as related resources on social media using the hashtags you see at the bottom left. And finally, we wanted to make a note about gender terminology during the meeting. During the meeting, some of the presenters will likely be referring to girls and women, but we do want to acknowledge that not all those who menstruate or use contraception identify as girls or women. So with that, I'm going to hand it over to my colleague Trinity Zan to get us started. Trinity?
Thank you, Kate, and welcome everybody. Thank you so much for coming back for day 2 if you were with us yesterday, and if not, then a big welcome to you today. I am just going to lead us through a quick, fun icebreaker energizer activity and then briefly look at our agenda. So next slide, please. Okay, we would like to hear from you. So we're going to make a fun word cloud. If you could please click on the link that you'll find in the chat, or you could directly put it into your browser. The question that you'll see is to name something new or interesting that you learned yesterday during our meeting. And just a pointer, it should say it there, but you can put a couple of words together, but you need to do it without any spaces. So if your comment is so many changes, write that all together with no spaces. So we'll give you a little while to enter your thoughts on what you learned yesterday, and we'll get a beautiful image. Yes, indeed, some women like no bleeding. I think that was very interesting. We saw a lot of data about the variety of opinions across the world with regard to bleeding changes. Very interesting comments about how much context does matter, that we do see a lot of variability across countries, across age categories. The importance of recognizing how our fields are evolving, both menstrual hygiene management as well as the family planning communities have been evolving over the years. Yes, I think people were really resonating with the context that's coming out loud and clear. The aspect of choice and how important that is, both for family planning and for the MHM fields. Diversity of views, diversity of changes. This is great. Thank you all so much. We'll just give it a little bit longer, maybe 20 seconds more. New acronyms, that's a great one. It's so hard when our fields come together and we're all familiar with our own words. Yes, good. Some comments about the need for strategic links, opportunities for integration, bringing the fields together. So I think this really reflects what we covered yesterday in terms of some of the basics from each field, some of the variety of changes that women experience and their opinions about those, and then setting the stage to talk some yesterday and more today about the opportunities for integration. But it looks like the clear winner is context matters. So I think we can probably cut it off there for the sake of time, but thank you all for responding to that. It's always fun to see our thoughts in motion. So I'll just give it a minute until we can see the agenda for today, and I'll quickly take us through that.
I think
we need to go back one.
Yep.
Thank you. So today we're going to have 3 panels in the first part of the meeting. So we'll be first talking a bit about measurement and indicators and how to do that in a consistent way, better and more consistent indicators. Then we will switch gears and really get into some of the biomedical domain and thinking about both desirable and undesirable aspects of CIMCs. And then forward looking into research and development, what types of new products and biomedical interventions may be possible to address all of the range of preferences and dislikes that we've been talking about. Then we're going to have a short break, and then we will be instructed in how we will break out into smaller groups to dive deeper into all of the topics that we have discussed over the 2 days, with the goal of really identifying some marching orders to develop a learning agenda and a broader call to action. So we'll do those breakouts and then have a very quick report out and discussion about the next steps. So with that, I will pass it over to Makerere, who will be taking us through the next couple of slides. So over to you, Makerere.
Welcome, everyone, and thank you for joining us for this really interesting 2-day meeting. So if you could, I'm Makerere Kara. I'm the Chief of the Research Division in the Office of Population and Reproductive Health at USAID. If you can move to the next. Yeah. So as Trinity said, we have some lofty goals here and identify research, program, policy, and product development priorities. Yesterday was a whole day of catching up, and this morning again, it's really just getting us all on the same page regarding what the measurement issues are, the biomedical issues, etc. So, but the really important part, at least from my perspective, is what the brain power you all bring to this meeting. And that's why the breakout groups are so important for us to start off on the main objective of this, which is to come up with agendas across very different domains. And from my perspective, of course, sitting in the research division, I'm really, really interested in the research agenda, both from the biomedical perspective, as well as from the program and behavioral perspective. I'm sure all of you realize that in such a short breakout session, we are not going to come up with the agendas, but I'm really hoping that you all will continue to work with us over the next few months and years to actually finalize the agendas and come up with priorities. And it's a global agenda. It's not that something that AID itself or only our partners are going to implement, but it's something we hope we are going to have a coalition around it so that other folks also work with us to ensure that we start getting answers to some of these major questions and issues that have come up yesterday and will come up again today. So with that, let me move on to the next slide. I don't think there's anything there. Yes, it's this objective of contributing to the development of a draft research agenda and a wider call to action. That's really the purpose. And as it says, we'll start the process today, but it's an extremely important start, and we really do hope you all will continue to work with us. Thank you very much. And with that, I'll pass it back on to Kate.
Thank you so much, Makerere. That was perfect, and just really appreciate you giving us that encouragement for the day ahead, but also for the breakout groups. So we hope that everyone will stay on for the breakout groups at the end of this session, and we'll talk more about that in a little while. But at this point, I'm going to hand it over to my colleague, Emily Hoppus, to facilitate the next session, which I think will be really interesting, looking at measurement and indicators around contraceptive-induced menstrual changes. Emily?
Thank you, Kate. I'm excited to introduce a couple of really great speakers who will be helping us begin our discussion about measurement and indicators this morning. We'll be starting with Dr. Julie Hennigan, who's a research fellow at the Burnett Institute. And she's actually joining us today from Australia. So she's pre-recorded her session, but she'll be here live for Q&A. So please post your questions in the chat and we can go ahead and get her video started.
Hello, everyone. It's fantastic to be connecting with you remotely from Australia. You'll have to forgive me for pre-recording my presentation. It's the middle of the night my time, but I will be tuning in live to answer questions and join the discussion. I'm really excited, actually, to see attention within this meeting to the importance of measurement. This is a topic that we've been grappling with in the menstrual health arena. And so what I thought I'd do in this short presentation today was to share some of what I feel I've learned so far, really as food for thought for our discussion. So when we think about measures and indicators, I think there's two really key initial considerations. First, thinking about what we measure. We want the measures that we're using to give balanced, meaningful pictures of the challenges, experiences, and outcomes that we're trying to capture. And this can seem really intuitive, but I think it can be quite hard to do, as I'll talk more about. Second, we want to measure things right. We go to a lot of effort and an expense to collect data and to design studies and monitoring efforts, but the conclusions that we're able to draw are really contingent on the quality of the measures that we use, whether these are reliable and whether they're valid. So what we measure. What we measure matters for a lot of reasons, but in part because it's what we pay attention to, and it's often how we judge success. If our measures fixate on only one component of our issue, it's likely that our interventions, our policy and program responses may also fixate on this topic to the neglect of other important aspects of the issue. And I think a really good place to start when thinking about what's important to measure is the nuanced understanding of experiences that we gain from qualitative research. In our problem theory, our understanding of the experiences of menstruation or of contraceptive-induced menstrual changes, and how these intersect with the environment and with other outcomes of interest. When we set out to develop some more consistent measures for menstrual health, we started out with a systematic review and meta-synthesis of qualitative research. Doing this allowed us to refine our understanding of menstrual experiences and highlighted the major themes that it might be important to measure. I've just got part of the model on the slide here, but in thinking comprehensively, we might want to take all of these things into consideration when we're building a framework for measurement. For our measure development project, we decided that this piece in the middle here around menstrual practices, or the behaviors that are actually undertaken to manage menstrual bleeding, were important and something that was frequently being measured in past studies, but inconsistently. And we then also determined to develop a measure for this other emerging theme, which was about how women and girls, they didn't just talk about the practices they undertook, they talked about how they felt about them, whether or not what they were doing, they felt was working for them, it was satisfactory, it was meeting their needs. We then developed measures for both of these concepts. And I think they're a nice example of how the way that we select concepts for measurement can influence our understanding. So for example, if we measure menstrual practices, like we've done in a lot of menstrual health studies, we might measure the type of material someone uses, or the number of times they change it in a 24-hour period. In contrast, if we measure the user's perception of their practices, we might measure if a respondent is satisfied with the material they're using, if they're able to change it as often as they need or want to. Both of these are consistent with the topics that we're interested in understanding menstrual health, but they're very different constructs and they give us a different window into this topic. We also expect that these measures may serve different purposes. When I'm communicating about these measures, I often ask which you think might predict or be more associated with genital infections, and which you might expect to be more closely related to anxiety or psychological well-being. Translating this, when it comes to contraceptive-induced menstrual changes, Is it the changes themselves, or is it women's perceptions of them that we think is going to best predict their satisfaction with their contraceptive? I've always really loved this early qualitative metasynthesis by Ruth Garside and her team that brought together studies around experiences of heavy menstrual bleeding. In synthesizing these experiences, her team found that the clinical definition of heavy menstrual bleeding in terms of the amount of blood lost really didn't line up with women's conceptualizations, which included other symptoms, the number of products they needed to use, whether or not bleeding was impacting their life. And when we think about contraceptive-induced menstrual changes, I can think again of clear parallels where we could get really wrapped up in measuring the physical changes, but forget the experiential aspects and the way, that women or menstruators conceptualize these issues. How we operationalize the concepts we want to measure then also really matters. We recently undertook a systematic review to audit the different measures that have been used in trials and nested studies of menstrual health interventions. Just on the concept of practices used to manage menstrual bleeding, we found 44 different practices that had been measured, and that no two studies measured the same set of menstrual management practices. And why I share this is that it suggests that our ideas about the obvious thing to measure, even when it just comes to menstrual management, are rarely the same. As I flagged at the start of the presentation, once we've decided what we want to measure, turning it into reliable and valid measures really matters. And there's a lot of different methodologies around this for different measures, and much too much to go into today. But an observation from our review is that a good place to start is to be really transparent and clear in the way that we define the concepts that we want to measure, and then to really transparently and clearly link them and explain how we operationalize them into measures. I think this transparency can really help sharpen our thinking and can help us critique the measures that we're using and to share them more meaningfully with others. So to rapidly sum up this food for thought, when our breakout groups are thinking about the development and use of measures, I think that we need to think long and hard about what we want to measure, how we're going to identify the concepts that are important to measure around contraceptive-induced menstrual changes, and how we can draw on user perspectives and past research to make sure that we have, comprehensive measures that are going to be meaningful. We then need to be thinking about how we can accurately measure these concepts, how we can clearly define, the concepts we want to measure, how we can transparently operationalize them into measures, and then test the validity and reliability of those measures. So thank you, and I look forward to continuing to engage on this.
So thank you so much for that video presentation, Julie. That was wonderful. I want to now pass it on to Orly, my colleague, to introduce herself and present a few ideas that build on the lessons learned from the menstrual health field that we just heard from Julie. Orly?
Thanks, Emily, and good morning, afternoon, or evening to everyone. My name is Aurélie Bruni, and I'm a social scientist with FHI 360 and the research lead for the R4S project. Today, I will offer some brief remarks to mirror the points that Julie covered, but from the perspective of the contraceptive field. Next. Starting with what we measure, this slide proposes a framework of the different domains we may want to consider for a comprehensive understanding of CIMCs. Starting on the left, these domains include the biological and physiological changes that occur as a result of contraceptive use, as well as the perspectives of users in terms of their preferences, attitudes, and experiences. The two combined then affect contraceptive use, menstrual hygiene practices, and users' lives. Next. Moving on to the how we measure, these different domains are covered by different types of research, including clinical, acceptability, behavioral, and epidemiological research. In general, there are some gaps and challenges in terms of measurement. So first, clinical trial data about bleeding changes can be rich and detailed, but it often stands alone and is measured using very technical definition that may not line up with users' conceptualization of the changes they experience. Then in non-clinical research, there can be a lack of precision around the measurement and classification of bleeding patterns, which can limit our ability to compare findings and look at associations with key behaviors. For example, large surveys like the demographic and health surveys can include data on impact, but they are limited in the information that is collected on CMICs. Until phase 8 of the DHS Women's Questionnaire, there was no differentiation between changes in menstrual bleeding and other side effects. And in the current version, there is a single response option that covers all types of CIMCs. We talked yesterday about the growing body of evidence on user experiences, but we still lack common standardized measures that could be consistently applied across studies. And finally, the different domains in the framework tend to be measured in different spaces and through different mechanisms, which can constrain our understanding of how they interact. Next. So to help move toward more comprehensive measurement efforts, my colleague Emily, who is moderating this session, compiled different categories of indicators for each of the 3 domains. These are all pulled or adapted from past research. I know it's a lot to take in, but we're hoping to further discuss them in the breakout rooms later today. So this can be a preview for those of you who signed up for the session on measurement. And I will pause for now and turn it back over to Emily.
Thank you so much to both of you for your presentations. We don't seem to have any questions coming in from the chat, so I'm going to take the prerogative as the facilitator and pose a few questions to both of you. So I'll ask each of you a separate question and then give you a few minutes to answer. First of all, Julie, for you, you focused on what we measure and how we measure, but I'm sort of wondering who we talk to factors into this. So it seems that who we talk to and the populations we're measuring are really important. And I was wondering if you could sort of speak to how that factors into measurement and perhaps what you've learned from the menstrual health field in that regard. And then for Orly, you mentioned that there's a lot lacking in the measurement tools that we have and the current data that we're collecting. And I was just wondering, how do we improve upon this? Who do we need to be talking to? What do we need to be doing to improve this measurement and to get better data in this field? So Julie, we'll start with you.
Sure, thanks. Hopefully you can hear me.
We can, thank you.
Great. So to the question of who we talk to, I think that this is really important as well, and this is why it's always difficult to do the whole topic justice in really short periods of time. I think something that is important to add is that obviously the measures that we use, what we measure and how we measure it is going to need to be appropriate to the particular research question and study design. So we might use, or have available or the opportunity to ask very different questions in something like a DHS, national survey compared to a clinical study or, a epidemiological study specifically around contraceptive-induced menstrual changes. So I think that our measures also need to be appropriate to these different study designs. And by the same, measure, who we talk to is also about accessing, populations and making sure that we're inclusive, and again, appropriate to that research question and to the study design. So again, in national surveys, that has a set sampling methodology that we're going to be using. And then we want to be mindful about these sort of unintended consequences or things that can change as a result of that. And then I think a separate question then for if you're doing a clinical study or doing different types of studies. Something that we have found in menstrual health that we published on a couple of years ago was that in the PMA 2020 surveys, some of the requirements for answering questions around menstrual health, so around menstrual management practices, required recent instances of menstruation. So it required respondents to have had a period in the last 3 months. And this actually had implications for how, representative our sample then was after that, or at least who was being included in answering those questions. So that's something that I think different issues might come up around contraceptive-induced changes, but I think something that we want to be really careful about and mindful of when we're looking at these different study designs.
Thank you so much. Orly?
Sure. So I'm actually going to give a very brief answer. I think to cover the gaps, actually, we need to talk to each other. As the slide was showing, I think measurement to some extent tends to be fairly siloed, looking at the different domains. And so this meeting is actually an opportunity for all of us to get together and exchange on what we have and where we see the gaps, and then put our collective brain power in developing measures to address particular areas where they may not be strong measurement, but also do a better job at covering the different aspects in our respective subfields.
Thank you so much. So we're actually at time for this panel, but please continue the conversation in the chat. It looks like we have a few questions for our panelists, so if you could look at those and answer, that would be great. And we look forward to continuing this conversation later this morning in one of the breakout rooms on measurement and indicators. So back to you, Kate.
Thank you so much, Emily. And for those of you who may have joined a little bit late, just a reminder that we will also be developing a written Q&A after the meeting. So for answers that aren't addressed, we'll be distributing a Q&A to registrants afterward. So now I'd like to hand over, I'm delighted to hand over the discussion to my colleague Lisa from the Population Council to introduce our next panelist. And Lisa, I'm going to ask you to introduce yourself and then kick us off.
Great. Good morning, good afternoon, everyone. I'm excited to be here today to facilitate this next session. I'm Medical Director of the Population Council Center for Biomedical Research and work with a team on development efforts to advance new sexual and reproductive health products. As practicing OBGYN physician, I appreciate, like many of you, both the positive and negative impact of contraception on bleeding and pelvic pain. This session will provide a high-level overview. Next slide, please. This session will provide a high-level overview related to the tools we have for improving the management of menstrual disorders and addressing the undesirable contraceptive-induced menstrual changes. Next slide. Again, please. As we have heard, menstrual health can have a substantial impact on individuals' quality of life and health. We have a limited understanding of the burden of these issues in low and middle income countries. This review is from 2004, and while these estimates and measures have limitations, it highlights how common these disorders are. There's large variability among studies with substantial cross-cultural and cross-country differences. Perspectives can vary, where problematic for one individual may be acceptable for others. When assessed by providers, prevalence increases, highlighting the unrecognized burden of menstrual disorders. Employing contraceptive approaches for medical management of menstrual disorders can be life-changing and a critical step to avoiding surgery. Recognizing contraceptives as treatment is a shift in perspective for many programs and family planning researchers that has been overlooked and underscores the important non-contraceptive benefits of these approaches. As Jackie will discuss today, contraceptives as a biomedical intervention can offer a successful management tool. In contrast, menstrual changes with contraceptive use can also result in frustration or method discontinuation. Beyond counseling, we need to have biomedical tools to support users. In this session, Kavita will discuss potential approaches to reducing these undesirable effects on bleeding and accelerating desirable changes. With that said, next slide. I'm going to pass along to Jackie, who will introduce herself and talk more about the biomedical interventions for menstrual disorders.
Thank you very much. Thanks for that introduction. I'm Jackie Maben. I'm a research fellow and consultant gynecologist at the University of Edinburgh, and I run specialist menstrual disorders clinics and offer a range of medical and surgical treatments. And in my research part of my job, I aim to develop better therapeutic and preventative strategies for those with menstrual problems. Next slide, please. So I'm delighted to be here today, and I want to just very quickly cover what typical and atypical menstruation will be, with this really a view to what is happening in a physiological manner rather than any kind of contraceptive-induced changes. I then want to run through our current treatment options with a focus on the hormonal medical contraceptions that we use day to day in our practice, and then move on at the end to just discuss how we can maybe improve treatment of menstrual disorders for those suffering them. Next slide. So to the first two aims, if you move it forward again, please. The brain clearly signals to the ovary to produce estradiol in the first half of the cycle and then progesterone in the second half of the cycle. And it's really the withdrawal of these two hormones, in particular progesterone, that causes menstruation. So this causes a real inflammatory response within the lining of the womb, the endometrium. And if you look inside with a telescope at this point, it's really like an open wound that completely repairs and regenerates after menstruation. But this concept of progesterone withdrawal or fall in progesterone being the trigger for menstruation, I'll come back to throughout my talk, particularly when I talk about some of the medical treatments and how they work. Next slide, please. So what is typical? Well, we've come up with 4 standardised terms to look at menstrual bleeding. Now, this doesn't include pain and PMS, but it's important to standardise this, and global experts have come up with the duration of bleeding, which is the number of days you bleed for, and it have shown that anywhere between 4.5 and 8 days is quite typical. The frequency of menstruation is the time from the day first day of one period to first day of the next period, and there's quite a wide variation of what's considered normal. The regularity is the variation in this length of time, so between the difference between the shortest cycle and the longest cycle, if that's less than 9 days, that's considered quite typical. And the volume of menstrual bleeding is a bit more tricky to define, but objectively is between 5 and 80 mils of blood per cycle. Next slide, please. So when things are not typical, you can have prolonged menstrual bleeding. Your periods can come too frequently or too infrequently. They can be very irregular or unpredictable, and they can also be heavy. And I'd like to just spend a little time discussing what heavy might be. Next slide, please. So objectively, it's this definition of over 80 mils per cycle, and that has a significant negative impact on quality of life. And repeatedly losing over 80 mils will result in significant anemia. So it really has a big effect on women. Next slide, please. But women in clinic don't come in saying how many mils of blood they lose, and what's more important is whether they say it's heavy. And what's acceptable to the woman on the left of your screen is probably very different to what's acceptable to the woman in the middle or on the right of the screen. And the take-home message here is, if a woman is telling you that their periods are too heavy, then they're too heavy. Next slide, please. It's incredibly common. It's very difficult to standardise between countries due to environmental, cultural differences, genetic differences, but also because we haven't standardised our definitions. And I think things are improving here, but the data that we do have shows that about 1 in 3 women will have menstrual dysfunction at some point in their reproductive life. So if it's not you, it will be your partner, your employer, your mum, your friend. And it's only set to become more common. Previously, women were pregnant or lactating and expected to have about 40 episodes of menstruation, and that's still the case in some parts of the world. But if we take the UK, for example, women now can expect to have 400 episodes of menstruation in a lifetime. So it's only going to become a bigger problem. Next slide. So what are the treatments that are available? Next slide. There are a range of medical and surgical treatment options. Many of our surgical options are fertility removing and are just not acceptable to women who haven't completed their family. So I want to take a look at some of our medical options in a bit more detail. Next slide. The hormonal preparations that we use, which are most of the medical treatments, really target the ovary and override the natural hormone production from the ovary. So the hormone coil or the LNG-IUS and the contraceptive pills and injections will prevent this decrease in progesterone at the end of the cycle that triggers physiological menstruation. And in doing so, they can significantly reduce the amount of bleeding because it keeps the lining of the womb very thin. And also it will prevent this massive inflammation within the endometrium, so it can be really useful treatment for painful periods as well. And in terms of figures that we quote, the hormone coil can reduce bleeding to up to 90%, about 40% for the combined contraceptive pill, and certainly the contraceptive injections can make a proportion of women completely amenorrheic, and I know that you heard about that previously. Next slide, please. So just to look at the LNG-IUS, it can cause a lot of irregular bleeding to start with, but with appropriate counselling, women experiencing menstrual disorders are willing to put up with that short-term annoyance for the long-term effectiveness. And you can see in the graph, as time goes on, the bleeding pattern does improve, but not every woman that will be the case, and some women experience real bleeding problems with these coils. Next slide. Which really brings us on to getting more effective treatment for women, not only taking into account what the user is wishing, but also as doctors getting better advising women which method may be more appropriate for them. Next slide. So I want to just move on to improving diagnosis and treatment. Next slide, please. So what we've spoken about so far are the symptoms of menstrual problems. Everything that we've spoken about is a symptom and not an underlying cause. And yes, we can treat symptoms, but it's a bit like pulling up a weed without getting the roots. And it's a short-term measure. And the only way to really effectively improve treatments is to define the underlying cause and treat that. And that will improve the treatments that we can offer. Next slide. So to do that, we come up with a categorization system for menstrual problems to try and look at the underlying causes with the acronym PAM-COIN, PAM being the structural disorders and COIN the non-structural disorders. So if you move to the next slide, thanks. The structural causes are things that you can see on examination or investigation, usually with ultrasound scan. A polyp, this is inside the womb here. This is a little outpouching of the lining of the womb. Adenomyosis is where the lining of the womb migrates into the muscle layer of the womb. And fibroids are an overgrowth of the muscle layer. And cancer can also present with bleeding problems. And all of these problems really are more amenable to surgical management, and medical treatments are slightly less effective, though there is ongoing research to try and improve that. Next slide. The structural causes are much more amenable to medical treatment, and things like bleeding disorders or the microscopic changes within the lining of the womb can respond very well to our current medical therapies and are much more likely to be effective, perhaps with the exception of the contraceptive-induced menstrual changes, which are under the iatrogenic category. Next slide. So I hope I've shown that improving diagnosis can improve management, but what about the treatments themselves? Next slide. I think we need to get smarter about the treatments that we develop and are using to treat the specific defects that people have in their endometrium. And I like the analogy about improving things with a light bulb moment, but I want to emphasize that a candle is also very effective. I mean, who wants light bulbs on their birthday cake? And appropriate use of our current medical treatments is a real useful treatment. But I want to just very briefly at the end talk about some of the new ways that we may tackle these problems. Next slide. So we're looking at the endometrial level, and as progesterone is withdrawn in the late secretory phase of the cycle, we've got this inflammation. We've shown that blood vessels very tightly narrow, and we've detected a very low oxygen level in the tissue of the endometrium at the time of menstruation, and have shown that this actually drives the repair process and limits menstrual bleeding. Next slide. But women with heavy bleeding don't tend to get this, and they have a higher oxygen level and prolonged bleeding. Next slide. And really excitingly, we think that we can treat medically with a medication just at the time of periods to really increase or trick the endometrium into thinking that there's low oxygen levels and drive the repair process. And we're really excited that this could be a new treatment for women with heavy bleeding. Next slide. So I hope I've covered all of the objectives today. I just want to signpost a website that we've developed for more information on menstrual health. It's quite UK based, but I think it's a good source of information about diagnosis, treatment and research. And next slide. it just leaves me to thank all the amazing people I work and collaborate with, the funders that have helped with the research, and also you for listening for the presentation. Thank you very much.
Thank you so much, Jackie, for that informative presentation. Kavita, please introduce yourself and share your presentation on the management of contraceptive-induced menstrual changes.
Good morning, good afternoon. This is Kavita Nanda, and I am Director of Medical Research in the Product Development Introduction Group at FHI 360. And we're going to switch gears a little bit here and talk about potential medical treatments and also prevention for contraceptive-induced bleeding changes. Next slide, please. This is an overview. I'm going to spend a little bit of time talking about the pathophysiology of contraceptive-induced medical changes, but without going into great depth. Talk a little bit about the role of counseling, which you heard about a lot yesterday, and an evaluation, but I'm going to spend most of the time talking about potential treatments as well as prevention. Next slide, please. With regard to the pathophysiology, one thing to note is that the bleeding changes that occur with combined oral contraceptive pills or with copper IUDs differ than with progestin-only contraceptives, such as the LNG-IUS, injectables, or implants. I'm going to present this at a very high level because just for this audience, and also because this talk doesn't allow for it. But suffice it to say that different contraceptives lead to various different endometrial changes. Additionally, there is a variability between women in an endometrial response to hormones and susceptibility to bleeding. Histological findings that are seen when researchers do serial endometrial biopsies or taking little pieces of the lining of the uterus don't necessarily correlate with bleeding patterns, and there have been lots and lots of studies looking at this over the past 35 years, including several WHO consultations. Next slide, please. As Jackie showed you, menstrual bleeding is complicated, and this is one of the models that we developed of normal menstruation, which is a highly controlled process of inflammation and tissue degradation. And when you have disruption of this coordinated process by contraceptives, you can have bleeding abnormalities. Next slide, please. Contraceptive-induced menstrual changes may vary by timing. So there may be differences between initiation and continuation of a method. For example, when a woman starts progestin-only contraceptives, the bleeding that starts with initiation may be secondary to rapid endometrial thinning, whereas as women continue their method and they have sustained exposure to progestin, either systemically or locally, such as with the LNG-IUS, there can be abnormal angiogenesis, which is blood vessel growth, and these blood vessels can be thin-walled and susceptible to bleeding, along with other changes that occur. Next slide, please. You heard yesterday that one of the most important aspects regarding contraceptive-induced medical changes is counseling. And I would agree that both pre and post-method selection counseling can be very valuable. Women should be reminded that these contraceptive-induced medical changes are not indicative of decreased efficacy and rarely affect safety. Next slide, please. In terms of evaluation, if pathology is not suspected and if a bleeding pattern is expected, initial management could just involve reassuring the woman. However, if bleeding changes continue to be bothersome, if the pattern suggests some underlying abnormality, such as IUD expulsion, for example, then a pelvic examination and/or further testing should be considered based on the individual clinical situation as well as the method. Next slide, please. With regard to treatment, as Jackie mentioned, for normal menstruation or physiologic menstruation, even if the bleeding does not meet clinical criteria for safety concerns, treatment should be offered based on how bothersome the bleeding is to the individual woman. However, because the etiology of these changes are not fully understood and is potentially multifactorial, the efficacy of these therapies is mixed. Next slide, please. So what are some of the common treatments that have been used? When you look at menstruation, there are various factors enzymes and proteins are involved both in normal menstruation as well as in contraceptive-induced medical changes or menstrual changes. And these include these factors such as MMPs, which are matrix metalloproteinases, something called VEGF, which is vascular endothelial growth factor, which leads to blood vessel growth or potentially overgrowth, hypoxia, which Jackie mentioned. There are interleukins. There are sometimes there is an abnormality of an enzyme called cyclooxygenase, particularly with women who are using IUDs. And so the common treatments are based on these potential findings and changes that have been noted. One therapy that's commonly used are NSAIDs, or non-steroidal anti-inflammatory drugs like ibuprofen and mefenamic acid. And the way these work is that they inhibit the COX-2 enzymes, which are involved in some of the abnormal bleeding that is seen. Sometimes there is an overactive fibrinolytic system, which means that clots dissolve and don't help to stop the bleeding. And so antifibrinolytics like tranexamic acid have also been used, particularly for bleeding that occurs with progestin-only contraceptives. Some treatments have involved giving estrogen, either in the form of estrogen alone or in the form of combined oral contraceptive pills to help to stabilize the endometrium and cause repair. Next slide, please. Less common and newer treatments that have been studied include mifepristone and ulipristate and UPA that help to inhibit progesterone and inhibit angiogenesis and thus lead to an inactive endometrium. A unique therapy that has been tried is something which is an antibiotic, doxycycline, which when used in sub-antimicrobial really low doses may help prevent uterine remodeling and matrix breakdown and lead to less vessel fragility. Anti-estrogens such as tamoxifen or raloxifene have also been used also to inhibit new blood vessel growth. And in the systematic reviews, there is a nice Cochrane review of this topic, and there are several other systematic reviews as well as a nice up-to-date that have been published. Some of these newer treatments do seem to work a little better than some of the more common treatments that I presented on the previous slide. Next slide, please. If you are faced with a woman who is complaining of contraceptive-induced medical changes, there is a nice flow chart here from the CDC selected practice recommendations. This is very similar to what the WHO recommends. And once again, the treatment should be addressed on an individualized basis. So for example, on the left-hand side here, if a woman is using a copper IUD, for example, and complains of unscheduled spotting or heavy or prolonged bleeding, non-steroidal anti-inflammatory agents can be very helpful. Whereas on the right-hand side here, or actually in the middle of the graph, if you have women who are using implants or injectables or other progestin-only contraceptives, treatment may involve either NSAIDs or hormonal treatment, as I mentioned, such as with combined oral contraceptive pills or estrogen. On the right-hand side of the figure here, if women are using combined oral contraceptives in an extended fashion or continuous fashion, what often helps to stop an episode of prolonged bleeding or spotting is just having them have a short 3 to 4 day hormone-free interval. Next slide, please. One thing that's really important to point out, though, is that all of these studies that have looked at treatments have in general found that treatments work in the short term to stop or shorten a bleeding episode, but they don't necessarily change bleeding patterns overall. Next slide, please. These are some of the challenges that have been found in some of the treatment trials. The doses of some of the medications have been limited by available therapies. So a lot of these medications are used for other indications. And so when used in bleeding treatment trials, the doses are limited by what's available. And some of these medications are also not available widely everywhere. A lot of these treatment studies have not been in low and middle income countries. Many treatment trials are small. They only look at short or single periods of treatment with short-term follow-up and a high dropout rate. And the outcome assessment and measurements have been very varied, and very few of them have looked at some of the newer ways of measurement and outcomes that we just heard about. The treatment of bleeding doesn't necessarily correlate directly with endometrial changes in response to treatment. And another thing to consider is that once these abnormal endometrial changes are established, it may be too late. However, there are very few studies on prevention. Next slide, please. One thing that I wanted to mention, though, is that despite these treatments only working in the short term, that a combination of treatment following the SPR guidelines, along with counseling, both pre and post method administration, can be very effective. I was a co-investigator in the recent ECHO trial, which looked primarily at HIV acquisition, where women were randomized to either DMPA-IM, a copper IUD, or an LNG implant, and followed for up to 18 months. And a secondary objective of this trial, as well as something that was needed in order for us to meet our primary objective, was that participants use their assigned methods. And so when we designed the trial, we looked at everything that had ever been done to help women continue their methods. And we built that into the counseling and treatment. And amazingly, participants in this trial used their assigned methods for 92% of the time they were in the study. This is a clinical trial, a randomized trial, so it's not necessarily generalizable. However, even though women didn't get to choose their method, many of them continued them. I did want to point out that at the end of the study, some women did elect to change their method, so some women continued purely for altruistic reasons. However, we think that the intensive pre and post randomization counseling, as well as the frequent clinical visits and support with repeated counseling and active management of side effects, did help women to continue using their methods. Next slide, please. I mentioned earlier that many of these treatments only work short term. So a few studies have looked at giving therapies to prevent these endometrial changes that occur and thus prevent bleeding from actually starting. And so I'm going to talk a little bit about those, although there are much fewer than with the treatment trials. Next slide, please. Several of these studies have looked at prevention of bleeding changes with the LNG-IUS. And I can provide references for these studies later, but as well as the doses and the treatment durations. However, in general, studies that have used either naproxen or transdermal estradiol, tamoxifen, mifepristone, or UPA don't really find much difference in the bleeding and spotting that occurs. These studies varied in duration from 30 days to 3 months. And this last study was for 6 months. And although they found less bleeding and spotting with UPA initially, later on they found more bleeding and spotting. So in general, although these were given either before or at the time of LNG-IUS insertion, they really didn't seem to help in terms of bleeding or spotting. Next slide, please. And one reason I think is that, as you've seen similar versions of this, these figures over the past couple of days, is that in general, the bleeding patterns that occur with the LNG-IUS are very favorable and acceptable. Amenorrhea, which is acceptable to many women, as you heard, does increase over time. And although it may be slightly less with the lower dose LNG-IUS systems, and also the bleeding and spotting days, even if amenorrhea doesn't occur, does seem to decrease over time. And so it may be very difficult to improve on this by adjunctive treatment or prevention. Next slide, please. With regard to other methods, there are even fewer studies. However, there is some reason for hope. One study that looked at an estradiol vaginal ring in women initiating DMPA did find fewer bleeding and spotting days in the estradiol group over 12 weeks. Another study found that mifepristone, also decreased both bleeding in the first 28 days, as well as episodes of prolonged bleeding over 24 weeks. And very interestingly, a study looking at low-dose sub-antimicrobial dose doxycycline in continuous COC users found that although there was no difference in bleeding or spotting in the first 84 days, women who received doxycycline had an earlier onset of amenorrhea, which is a potentially favorable menstrual change. Next slide, please. So in conclusion, the mechanisms of contraceptive-induced, sorry for the typo there, menstrual changes are still not completely understood. And histological findings vary and are not necessarily correlated with bleeding patterns or hormone levels. Treatments only work temporarily, but along with counseling, both pre and post-method administration or use can lead to high continuation rates. And prevention of these adverse endometrial changes and acceleration of amenorrhea might work better than treatment. Next slide. Thank you.
Thank you so much, Kavita. That was an excellent presentation. We are running a little late on time, but we are fortunate to have Billington Volika here to join us today to provide a perspective from the provider angle on the management of these menstrual disorders in low and middle income countries. Dr. Volika is a OBGYN trained provider and researcher in Zambia and has a nice perspective to share. I'm hoping, Billington, are you there?
Yes, I am. Thank you, Lisa,
Great.
for that kind introduction. Yeah,
Billington, I'm sorry, Billington, would you mind introducing yourself? And then also one question that came up that I'm hoping you can also address was who among providers can actually address these changes, diagnose and treat as well? Thank you, Billington.
Thank you, Lisa. So you've almost introduced me. I'm Billington Volika, practicing in a low middle income country, Zambia. I am an obstetrician and gynecologist. I've worked with Lisa in a couple of studies in the past, so she's not a stranger to me. So I want to thank Kavita and Mebin for their very elaborate presentation. In fact, they've summarized what I had to say. However, giving a perspective of practicing in this part of the world, it needs a lot of understanding of the physiology because we don't have a lot of laboratory support to make a diagnosis, as maybe the privilege for some of you, my colleagues. So the menstrual disorders are managed by low-level cadres, which include nurses, but usually it's better if done by a medical doctor. So we've been given the pathophysiology. One of the tasks that is to make sure that you make a proper diagnosis. If it is an ovulatory abnormal uterine bleeding, you would start with the basics such as non-steroidal anti-inflammatory drugs and fibrinolytic drugs. If they don't work, you end up with the combined oral contraceptive. Another challenge is to make a diagnosis of non-ovulatory abnormal uterine bleeding, for which you may have to replace the progesterone or use the LNG system. Many times we have women coming with problems related to the contraceptive that they are using. For example, women on implants, they'll come with intermenstrual bleeding, prolonged bleeding, sometimes amenorrhea. So the first line of treatment in this case is the non-steroidal drugs. We may try antifibrinolytics, but ultimately we end up with the use of COCs. The other culprit that is commonly seen by our nurses or what we call clinical officers, they'll come with after injectables, spotting, prolonged periods. Again, what we teach them in the practice is to start with the cheapest drugs, which are the non-steroidal anti-inflammatory drugs. But also, if no benefits are coming up, they also end up with the COCs. The last group is that of the adolescents. We all know that they go through a painful time soon after their menses. They have painful periods. Some of them have prolonged periods, which make them miss school. But then again, we try from the cheap drugs, non-steroidal anti-inflammatory drugs, and any other supportive drugs that may help or not help. But ultimately, we end up with the COCs with associated stigma that we are using these in young people. So that's the little that I had to add on Mebin's and Kavita's presentation. Thank you very much.
Great, thank you so much, Dr. Relika. Unfortunately, we're out of time. I wanted to thank all of the panelists, and Kavita and Jackie, if you don't mind addressing some of the comments in the group chat, and again, these will also be available in the distributed Q&A after the presentations today. Thank you so much, and I'll turn this back over to Kate.
Great, thank you all so much. That was such a rich discussion, and I think it's just an amazing testament to all of you that you could share so much information and make it so engaging and interesting. So really appreciate this, all of your contributions. So I'm going to go to the next slide and hand this over to my colleague, Dr. Amelia McKenzie, who's going to facilitate a panel on product development and contraceptive R&D. Amelia?
Great, thank you, Kate, and welcome to everyone for what I expect is really going to be an intriguing panel. In this section, we'll be discussing new products and biomedical interventions that are being developed and how to incorporate user preferences at all phases of development and introduction. Before we begin, I'd like to briefly introduce the panelists, and I'll ask each of them to turn on their videos for the panel if they're able to facilitate discussion and interaction. Diana Blythe is a chief of the Contraceptive Development Program in the Division of Intramural Population Health Research at the National Institutes of Child Health and Human Development, or NICHD, at NIH, or the National Institutes of Health. Dr. Blythe is the director of the Contraceptive Clinical Trials Network, which is a network of uniquely qualified clinical sites that are capable of conducting research on new investigational products for male and female contraception. Gustavo Doncel is the scientific and executive director of CONRAD and professor of obstetrics and gynecology at Eastern Virginia Medical School. His work is funded by USAID, NIH, and the Gates Foundation, and he's been doing research in reproductive health, and in particular contraceptive R&D, for more than 30 years. His efforts have been focused on novel contraceptive targets, biomarkers of reproductive health, and development of innovative preventive technologies. Lenita Dorflinger is a distinguished scientist and director of the Product Development and Introduction Department at FHI 360. Over her 35-year career, she has overseen contraceptive R&D from early stage development to clinical research, regulatory approval, and introduction. She currently leads FHI 360's Contraceptive Technology Development Program, which has a focus on mid to long-acting approaches appropriate for low-resource settings. And Kirsten Vogelsson is a senior program officer at the Bill and Melinda Gates Foundation. She has over 20 years of experience funding research and development of contraception and other reproductive health products suitable for low resource settings. And this includes time at the World Health Organization at USAID. She currently manages a portfolio of contraceptive R&D grants and provides technical and strategic support to the Foundation's Contraceptive Technology Initiative. Well, welcome to the four of you. We're so pleased to have you join us today. I'd like to start off with Diana. With your work directing the Contraceptive Clinical Trials Network at NICHD, could you tell us how methods currently under development will impact the menstrual cycle, and what research is needed to better understand and anticipate that impact?
Sure. Are you able to show the slide that I sent? Because I wanted to give an example.
Yeah.
Yes. So what you're looking at here is bleeding profile from women who are participating in a clinical trial of a method. It's a contraceptive vaginal ring that gives a progestin and estradiol, and they can wear it either continuously or cyclically. Each line is an individual woman who's recording her bleeding over a 6-month period. And if she has no bleeding, she puts a green or a 0 in. If she has spotting, which is defined as not needing protection, it's blue. Light bleeding is orange, and then regular and heavy bleeding are different shades of red. So you can see that although all the women are using the same product, and Kavita and Jackie gave great talks on what would cause bleeding, you can see that the women, what you you want them to have the same reaction to the same product, but they don't. So no matter how much counseling you give them about what you think they're going to experience, it may not be the same. So for instance, up here, the women is just sorted with the least number of days of bleeding or spotting down to the most. And so the women up here go into amenorrhea and for the most part stay there. And then the women here who have spotting, which may or may not be bothersome to them, they'll have that periodically, but it's somewhat unpredictable. Then you get women who have, looks like fairly regular bleeding, even though they're using this product continuously. And then there are women who have bleeding all the time and obviously wouldn't like this method. It doesn't work for them. In some cases, it gets better. In other cases, it gets worse. So the generalizations are not clear. The next group down here are wearing it in a cyclical way in that they take it out 2 days, only 2 days, for a quick progestin withdrawal. And you can see that that induces cycles for most people. Now, there are some women who still will have amenorrhea. And if they can have that and they want that, that's terrific. But if they can't have it, if their bodies, for whatever reason, are not reacting to this method by allowing them to have amenorrhea, you can't tell them just stick it out, it'll get better. It may, but it may not. But they can introduce a cyclic range if they just do this on and off. And I only wanted to demonstrate this because we have the best of intentions to try to give women what they want, but when we give them the chemicals or the hormones that we think will produce a specific pattern, they may not react to it in the way that is typical. Not clear what typical is when you see all these differences, but you may not be able to give them amenorrhea if that's what they want, or they may have amenorrhea even if they don't want it. So just a little bit of the frustration of trying to use what we know about hormones to produce a pattern of bleeding and not being able to do it the same for every woman is what we face, and it's a challenge. So that's pretty much what I wanted to say.
Thank you, Diana. I think that's really rich information and what a great visual there as well. Gustavo, it'd be great to hear from you next. And I wanted to ask you about how we can incorporate user experiences and their wants and their needs around contraceptive-induced menstrual changes that Diana alluded to and that we talked about yesterday into our R&D work. So what can you tell us from your experience and specifically some of the current work that you're doing at Conrad?
Okay, so thank you, Amelia. And good morning, good afternoon, good evening to everybody. I'm Gustavo Doncel. I'm the scientific director of Conrad, and Conrad is for those of you who are not familiar with it, is a nonprofit biomedical R&D organization that is nested within Eastern Virginia Medical School, and our mission is to improve global health through the development of innovative user-centered technologies, being focused for many years on contraceptive R&D and HIV prevention, STI prevention. So I think that it was clear from yesterday's excellent talks that there are still differences in preferences in women about amenorrhea versus, say, normal cycling. But I think there's a consensus that nobody wants, or most women don't like heavy menstrual bleeding or prolonged menstrual bleeding or irregular and scheduled bleeding. So that motivated us to think about one possible way to mitigate this irregularities in bleeding. And that was the rationale to develop a program, You Choose, that has been recently funded by USAID, and whose aims are the development of a personalizable, new, long-acting, implantable contraceptive, the development of a human-centered designed inserter that enables point-of-care loading, and of this pellet-based implantable. And finally, a clinical trial to ascertain with state-of-the-art methodology the impact of widely used contraceptives on cervicovaginal and female reproductive tract mucosa. Each one of these aims has a component of capacity building also in African countries. I think it's very clear, and I like Kavita's and Jackie's review of the mechanisms. There are many mechanisms that have been postulated as underlying the irregularities and the breakthrough bleeding that occurs, and they're the influence of contraceptives, in particular progestin-only contraceptives, with inflammatory components, vascular components, tissue repair components that have not been properly defined really as to exactly what is it, which one prevails in a certain case. That said, I mean, of course, that has elicited numerous treatments with varied results, as in Kavita summarized. We've used a system, a pellet-based system that we developed with another USAID award to release and deliver antiretrovirals for HIV prevention. That is based on pellets, on resorbable pellets that can actually interchange and contain different drugs. In this case, the concept is to use a progestin for safe and effective contraception, and depending on the medical history and the preference of the woman seeking contraception, use a compound that may mitigate, alleviate the irregular and heavy bleeding that she might experience. And that can be changed, could be for a shorter time or a longer time. Initially, we've chosen estradiol as the sort of a safe proof of concept compound, but we're certainly open to other alternatives, and the newer versions of SERM and sperm are under consideration currently. This has to go together with an inserter that enables the point of care loading of pellets that contain one drug or both drugs or the other one. And that flexibility needs to be engineered. There is nothing in the market that allows that flexibility. We, through a process of human-centered design with healthcare providers and end users, we came up with a design of a safe, effective, ergometric, flexible trocar that enables this point of care loading and personalizable contraception. And finally, the last aim is, as I mentioned, using state-of-the-art techniques. There's the biology of how the female reproductive tract responds to contraceptives have moved forward, but the translational studies determining the impact of widely used, highly effective contraceptives have not followed through. And we're proposing to marry both and get a better understanding of what's the impact in the female reproductive tract of this widely used, both novel and existing contraceptives. So I'm going to stop here because I'm mindful that we're short on time.
Thank you, Gustavo. I appreciate that. I know there's so much that we'd love to talk about here. We are limited. But Lenita, I'd like to turn to you next and ask you about sort of the process of contraceptive R&D. So given that it is a long process, I was hoping you could discuss a little bit about what we should be considering now and at different stages of product development. So for example, in our pipeline at FHI 360, what are we thinking about now, considering that they're, we're developing products for users that may be 10 years down the road when the product is actually introduced and put on the market?
Thanks, Amelia. I don't think anybody that does contraceptive R&D cannot be thinking about the long-term process that it takes, particularly for long-acting approaches. And so you have to be thinking down the road 10 years. FHI has a number of new contraceptive product collaborations, but clearly the largest emphasis in our program is on developing new long-acting delivery systems for existing steroids, specifically progestins. And these include a couple of microneedle patch designs, 2 different biodegradable implant systems, and several longer-acting injectables. And we're using 3 different progestins. And so we know that each of the progestin-only approaches we're developing will certainly produce menstrual changes, either bleeding changes or potentially other symptoms. So how do we deal with that knowledge? Our goal is to do what we can in the design stage to learn from other research in the past and then try to optimize these new delivery systems in ways that would reduce product characteristics that we think might be most highly correlated with a negative impact. So for example, trying to design formulations to reduce or eliminate early drug peaks that might happen immediately after initiation, like we see in some systems. Or from an overall pharmacokinetic perspective, we're striving to achieve, to the extent possible, more consistent PK release. I guess ideally it would be 0 order release. And thinking that if we can stabilize the PK profiles, women might have fewer issues that are linked to drug delivery variability. And we specifically assess whether these designs can achieve our goals in a preclinical phase and then refine and optimize the design or the formulation as necessary. We also incorporate, like many do, acceptability and user design research to better define parameters that are of greatest importance to potential users in order to understand the user preferences and attitudes towards certain method attributes, individual characteristics of users that might correlate with certain preferences, and overall drivers of method choice. And you heard several data from several of our trials around this yesterday, particularly perceptions of menstrual changes. And we also build acceptability and preference components into the larger phase 3 clinical effectiveness and safety trials. And these types of data help inform future labels for new products as well as counseling materials. I think many in this audience who know a lot about hormonal contraception know that there's a wide inter-individual variability in the pharmacokinetics and pharmacodynamic responses among women. It's really quite remarkable how large the variability is. What we don't know is how this variability in PK/PD response might correlate with susceptibility to certain types of contraceptive-induced menstrual changes. I think Diana spoke to this as well. So something we're just starting to do in our program is to build a pharmacogenetic or pharmacogenomic assessments into our trials, something we think might help us assess potential differences in responses, as well as learn how individuals' genetic makeup might inform a predisposition to certain side effects. And these data can then be used to better inform product designs in the future. And we'd be delighted to collaborate with others to advance the science in this area. So I think a lot about whether we can really predict what method preferences will be like 10 years from now. How much might preferences actually change over the next decade compared to now? I know many things I do naturally today, or things that I like today, I wouldn't have expected appeal to me if I were asked that 10 years ago. But I think the only thing we can be certain of is that there'll always be a breadth of desire and preferences. And so it's very important for us to be able to provide the best data we can to help potential users choose among the new methods that we and others develop. And I think this issue of better, more consistent measures is one of the important topics of this meeting, as we heard earlier this morning in particular. And to me, product developers like ourselves and Conrad and NICHD and working with and the Gates Foundation, USAID, need to encourage this collaboration to develop uniform, standardized, validated ways of collecting data on key outcomes. And then we have to agree to use those measurement tools. So I think this includes a variety of types of data, whether it's from clinical trials or acceptability and user preference research, or product development that crosses the family planning and menstrual health fields. So I'm really excited about being able to think that this area might be advanced following this meeting. So thanks, and back to you, Amelia.
Great, thank you. Kristen, I'd like to tap you next and ask, what do you see that you think is still missing from the R&D field? And are there, some steps that you and others at the Gates Foundation are really thinking would be key to filling some of those gaps?
Kirsten's muted.
Thank you. Thanks, Amelia, and thanks to my fellow panelists for raising really good issues and topics that I think as an R&D field we're really aligned with across the implementers and the funders. You know, we heard yesterday and we've learned and relearned over decades of research and programming in low and middle income countries that undesirable bleeding side effects of hormonal methods can cause disruption to multiple aspects of a woman's life. Some women are able to accept side effects of irregular and unpredictable bleeding. Some women might seek bleeding effects if the result is lighter bleeding or amenorrhea, but other women are not able to accept a method that results in these changes. Bleeding effects in many cases result in non-adoption and discontinuation of otherwise safe and effective methods. The Gates Foundation seeks to implement a user-centered contraceptive R&D strategy, and we've recently defined non-hormonal contraceptive drug discovery as a major aim of the Foundation's work. Novel drug compounds must be preferable to women in order to justify a high-risk, long-term investment strategy, and our goal is to develop products that better meet the expressed preferences of users and potential users in low-resource settings, including an improved side effect profile. Gustavo just spoke about the importance of addressing user needs and preferences in contraceptive R&D, as did Lenita. We know that women may consider other product features, such as side effects, as important as safety and efficacy in choosing which contraceptive method they want to use in different points of their life. The Gates Foundation has an active product development pipeline that focuses on innovations in formulation and delivery of hormonal contraceptives. And Lenita just spoke about some of the efforts that we're partnering with FHI 360 in moving forward, including Makerere patches, for example. We're also working to build a scientific program in drug discovery for contraception. This is an area that has been underfunded for decades. We initiated this effort by making multiple investments in tools and platforms for drug discovery and are now building a program to support novel target identification using tools that have been developed and applied to drug discovery programs in other health areas. These efforts are very new, so I'm not able to describe for you any results of this developing program, but I will mention a few of the factors that we're considering as we elaborate a full investment portfolio in contraceptive drug discovery. The first is that we need to consider the biology. This is an obvious point. Kavita from FHI 360 earlier introduced some of the biology of menstrual bleeding and bleeding effects associated with contraceptive use. And by net definition, the Foundation's new non-hormonal discovery program is examining potential novel pathways of drug action that do not intersect with the traditional steroidal pathways activated by hormonal contraceptives. For example, rather than broadly suppressing ovarian activity, as current contraceptives do, hormonal methods do, we might look to identify compounds that very specifically inhibit follicle rupture, while still allowing for ovarian function that's fundamental for regular menstrual bleeding. Second, we need to incorporate assessment of potential bleeding effects early on in drug discovery and drug development. We can think about developing and including tools and secondary assays that may tell us about the potential to disrupt hormone signaling and affect bleeding as we're developing and screening potential novel drug compounds. We can't ignore this potential effect, and to bring in these kinds of tools and assessments early on in development will allow us to make some strategic decisions about which product candidates to move forward. Bringing in tools early in development, incorporating steroid assays for ovarian targets or examination of ovarian effects will absolutely be essential as we seek to advance only those compounds that offer the most promise in providing women with preferable products. Third, as I mentioned, we really, we're at a great place now that we can leverage drug discovery tools that have been applied to other health and medical areas. One example in our current portfolio is looking to the growing field of organoids. This presents opportunities to model, for example, endometrial tissue and its response to mimicked hormonal regimens. The foundation is not investing in contraceptives that act on the endometrium, but we are investing through Kevin Osteen at Vanderbilt, and there are others looking at endometrial organoids, organ-based biology and toxicology models that will help us screen compounds to mitigate bleeding side effects. These aren't currently high throughput, but again, it's a way that we can bring in these assessment tools early on in our screening and drug discovery processes. Finally, we need to acknowledge challenges. While we're optimistic that concerted efforts really can bring forward a new generation of contraceptive drugs that have improved side effect profiles for women, for users, for potential users, but we do need to acknowledge the challenges. One specific challenge is the lack of readily available cheap animal models that replicate menstruation and that could model breakthrough bleeding. Our field has used primates in the past. These may be suitable, but they're not really a model that can be used early on in drug discovery due to cost and practicality. So as we build our non-hormonal drug discovery portfolio, we'll need to identify appropriate models for both new contraceptive methods as well as potential adjunct therapies to mitigate breakthrough bleeding related to hormonal disruptions. Again, we're optimistic. We're excited about being able to leverage existing tools and platforms for drug discovery. We know it's a high-risk, long-term effort, but we're very motivated to bring forward, again, a new generation of contraceptive products that are more acceptable and really women would want to use. Thanks.
Thank you, Kirsten. I appreciate those comments. We are running short on time, but I do want to ask. I'm hoping I'll have time to ask one quick last question for everyone and ask for a really quick 20-second, one-sentence response from everyone. And I was hoping we could sort of look to the future. I think a lot of us in research have that kind of dream proposal or project that we have tucked away in our desk drawer that we'd love to work on if we weren't, constrained by the annoying realities of time and money constraints. So I'd like to ask you each, if you could receive or award unlimited funding, what would be your dream study, very briefly, to better understand menstrual changes in the context of contraceptive R&D? And Kirsten, I'll have you go first.
Oh, thanks, Amelia. We heard a lot about user responses to bleeding yesterday. I do think that we need, I would love to have more data from women in low and middle income country settings to inform both product development and programming for contraception.
Great, thank you. Gustavo, could we hear from you next?
It's muted.
You're on mute, Gustavo.
Okay, very good. I was asking if I was unmuted. So thank you. Being who I am and what I've done for more than 30 years, I have to go with my dream study would be one that intersects, takes part of what Kirsten said about the biology and how we need to understand what's going on and what could happen, and the need test pharmacogenomics. And I will do a study on mechanisms, try to elucidate more in-depth and individual mechanisms that lead to contraceptive-induced menstrual changes, so that our therapy, our approach could be science-based and not empirical.
Great, thanks. Diana?
So girls start losing their follicles, I think, in utero and certainly after birth and throughout life. And what I would love to do is capitalize on some of the work done by the fertility preservation groups who are trying to stop follicular development in order to do chemotherapy and then restart. So that if you could stop follicular development and put the ovary basically into suspended animation, that would be a terrific thing. And then you just restart it when you want to have children. That would be my dream project.
Thank you. And Lenita, could we wrap up with you, last but not least?
Sure, thanks. I think anybody that knows me knows that I'm kind of an amenorrhea freak, for better or worse. So if I had unlimited money, I would fund research to identify and develop a safe and a short use adjunctive therapy that could rapidly and effectively induce amenorrhea, and initiators of long-acting progestin methods that would, if they desire, bleed-free contraception.
Great, thank you. We've had some wonderful questions here in the chat, but unfortunately we are running out of time. But I will remind everyone for the whole meeting for both days that we'll be pulling out those questions and giving written responses to make sure that we give attention to all of them. So with that, I thank everyone on the panel so much for your time and your wisdom and your thoughts and your what you shared with us. And I'll turn it back over to Kate for the next session.
Great, thank you so much, Amelia, and everyone. That was really fabulous, just so fun and so engaging. So actually, we are going to give you a 5-minute break because, as Mahira said at the beginning, we have our jobs cut out for us. So after the break, we are going to go into Zoom breakout rooms, which hopefully will be really fun and engaging. But we wanted to give you all a short break. Can you go back one? I heard in our meeting recently to do a one thing 5-minute break, meaning use the bathroom or check your email, but not both. So pick that one thing. And then for those of you who feel like you don't need a break, in about 2 minutes, we're going to officially do the worldwide launch of a new video we've developed with the Knowledge Success Project on contraceptive quote unquote side benefits. It came out really well. I'm excited to share it with you all. So we'll do that in 2 minutes. If you want your full 5-minute break, go for it. We'll come back at 10:37 for Eastern time. Thank you all so much. And we have a couple people who are just joining now. For those who are just joining, we're on a break and we'll be reconvening in about 3 to 4 minutes.
Side effects of contraceptive methods are often viewed negatively. Research shows that individuals often discontinue or decide not to adopt modern contraception because of real or perceived side effects. In many cases, women make a logical calculation as to whether side effects outweigh the risk of unintended pregnancy. But what if, instead of just focusing on contraceptive side effects, we also considered potential side benefits? Some side effects are clearly undesirable for users and can negatively impact their well-being, lifestyle, and in rare cases, health. But most methods also have potential non-contraceptive health and lifestyle benefits, which might not be adequately discussed or appreciated. Globally, we need to do more to educate policymakers, program managers, healthcare providers, and community members about these potential advantages. In addition, researchers and product developers can do more to design new products with non-contraceptive attributes that will be desirable for users. Depending on the method, some of the potential side benefits of hormonal contraception include reduction in acne, improved menstrual regularity, reduced menstrual cramping and/or pain, lighter periods, pause periods, also known as amenorrhea, and reduction in symptoms of endometriosis or other menstrual disorders. Some contraceptives can also prevent or reduce the risk of developing certain health conditions, such as ovarian, cervical, and endometrial cancers, uterine fibroids, ovarian cysts, ectopic pregnancy, and iron deficiency anemia. In addition, male and female condoms offer protection against sexually transmitted infections, including HIV. These are all substantial advantages that should not be overlooked. At the same time, methods will not have the same benefit for everyone. So, women should talk to their healthcare providers about what health and lifestyle benefits they see as desirable. And providers should consider these preferences when helping women selecting a method to best meet their needs. Similarly, if women experience side effects that have a negative impact on their well-being or lifestyle, it is important for providers to take these concerns seriously. Also, in some rare cases, use of contraception can have negative health consequences. If a woman has concerns, she should discuss this with her health provider. Several actions can help us expand our awareness of contraceptive side benefits. Specifically, governments and partners are encouraged to update family planning guidelines and trainings to reflect non-contraceptive benefits, increase awareness of these side benefits through educational campaigns, engage the private sector to ensure that all segments of the market are reached, and continually consider non-contraceptive side benefits in the development of new products and in discussions about investments in family planning. As we seek to address individuals' needs, it is important to break down silos when it comes to women's health and women's lives. Many women use contraception to avoid unintended pregnancy. Many others may choose to use contraception because of other potential non-contraceptive attributes. So, it's time to expand our thinking as well as the language we use. While some side effects are undesirable, some side benefits can offer substantial advantages to women around the world.
Great, thank you so much. I hope some of you were able to see that video. Again, this was the international debut of that video, which we developed in collaboration with Johns Hopkins CCP and FHI 360 through the Knowledge Success Envision FP projects, which are both USAID funded, and also in partnership with the CTI Exchange, which is funded through the Bill and Melinda Gates Foundation. So we are now going to move into breakout rooms, and we're really excited for this part of the session. As you can all imagine, the Zoom logistics are exciting and a bit harrowing, but we're doing our best and have a great team in the background who's working on that. Can we go to the next slide? So as we've been talking about the last 2 days, and as Mahira reminded us as we opened the meeting, one of our key goals out of this 2-day session is not to just have this be a one-off discussion, but to really be the launch of hopefully a new collaboration across both the contraception and menstrual health fields to work together to develop a draft learning agenda and then a wider call to action. And part of the reason we're framing this as a call to action is that part of this will include a research agenda, and then also part of it will include recommendations or considerations both for researchers, for donors, and for service delivery groups and policymakers. Next slide. So what we're going to do is break you all into rooms. You see the 5 topics here. There are 10 rooms total, 2 rooms per topic. Each of the rooms will be facilitated, or rather co-facilitated, by assigned facilitators, and they'll give you instructions on the technical content that you'll be discussing once you get into the room. We tried to accommodate everyone's request of where they would be assigned, but some didn't express a preference, or if there were any mix-ups, we asked that for your forgiveness and forbearance, and just stick with the group that you were assigned, and hopefully it will be interesting no matter what group you're assigned to. Next slide. Great. And so just for those of you who haven't used the Zoom room, this may seem a little bit overwhelming. It's incredibly easy, I assure you. You may just pop into the breakout room in a second, or you may need to accept an invitation. So if there's a breakout room that says the host is inviting you to join, just go ahead and click on that. Just an FYI that the sessions in the breakout rooms will be recorded. We are hoping that there will be lots of time for interactive discussion. The facilitators will be guiding the discussion, and just for the sake of making things easy, we ask that you use the raise hand icon, and you can, if you hover over the participant list, you'll see the raised hand icon. If you can't figure this out, don't worry, you can just go ahead and unmute yourself to speak. You can also insert comments in the chat bar, of course, if you don't want to speak or you're not able to unmute yourself. If you've used a Zoom room before, breakout room before, will be receiving 10-minute and 5-minute warnings as the time winds down. And so that's just a warning to sort of be mindful of the time. You'll then get a 2-minute warning when the session's about to end, and you can either wrap up your discussion then and then leave the room, or you'll be popped out automatically when the time runs out. And so if you do manually leave the room, make sure you click leave room as opposed to leave meeting. If you do accidentally leave the meeting, just come back in through the original link that you received. So we're going to hand it to our fabulous colleague Audrey to hopefully assign us into breakout rooms, and we'll be together in these breakout rooms for 30 minutes. And again, we'll be rejoining in plenary to do report out and talk about next steps afterwards. So I think it'll take just a brief pause to load the breakout room, so just give us one moment. Welcome back to plenary, everyone. I hope that worked. Our group worked really well, so hopefully it did for others too. Again, a huge thanks to our colleague Audrey, who managed all of that behind the scenes, which just took a huge amount of work. It went so at least hopefully smoothly for everybody else. What we're going to do now we're going to do a rapid fire, and you can see the breakout room facilitators on the screen hopefully, and we're going to ask each of the facilitators to just do a 1-minute sort of highlight takeaways from the breakout groups. So Orly, can I ask you to go first? Are you there?
Yes, I'm here. Sure. So we had a good discussion around measurement. Some of the key points were that when we think about user experiences, we need to take a broad view to include their social environment and their perceptions and not their experiences. Generally, as a group, we agreed that there are few data sources or opportunities that look at the different domains together. However, there is an exciting study. Our colleague Ekwa Yanka from CLU in Germany told us they are conducting a study in India, South Africa, and the US that will be looking at different dimensions, and they are developing a scale on attitudes to bleeding as part of the study, with the results expected in January of next year. In terms of the measurement, we also talked about the potential to look at big data, especially apps that may be collecting information on bleeding patterns, etc., but also adopting measures from other fields, including we talked about charisma and around HIV, like scales around unintended consequences from PrEP use and whether we might be able to adapt them to contraception. I think I'll end there because I'm probably at the end of my minute.
Thanks, Orly. That's great. Emily, are you there for a quick summary or highlights?
Yeah, I'm here. Just a few points from our discussion. It was a great discussion. One of the first things we talked about was the importance of understanding the larger sociocultural context and social norms and how those things impact basically everything that we want to measure and how we capture those in measurement. We also talked about how it's important to sort of balance measurement tools when it comes to making it easy for people in the field to use, but also capturing everything we need. And then we also talked about CLUE and the data that they're collecting, and just sort of the importance of digital data overall, and how period tracking apps and a lot of different reproductive health apps are capturing a lot of data and how we might be able to tap into that.
Great, thank you so much, Emily. Amelia and Funmi, can I ask you to go next?
Yeah, hi. I think we also had some great discussion here. I think it sounds like there may have been some overlaps, that there was a real interest in thinking about how perceptions of menstrual changes relate to broader sociocultural norms about menstruation, sexuality, and also broader gender norms as well. And I think there was also a real interest in making sure that as we're asking any of these questions about menstrual changes, that we're thinking about potential differences that may exist across the reproductive life course. So things that might be very differently perceived when someone first menstruates versus when someone is entering perimenopause, and all the stages in between, and how that could be impacted by different stages in reproduction and fertility as well. So it was a really great discussion, and I'm looking forward to it continuing.
Great, thank you, Amelia. And Holly, can I ask you to go next? And we're switching, oh yeah, sorry. That was the socio-behavioral and user experience group, and so Holly also had a group on that. Can you speak for a minute, Holly? Oh, Holly, we're not getting your audio. You may need to unmute. And if not, maybe Lee, you can jump in.
Sure, I'm happy to. In our group, we had a lot of...
Oh, I'm sorry.
Oh,
okay, we got you now, Holly.
Oh, go, Holly.
Oh, I'm sorry. Yeah, I had to rejoin, and I think my privileges might have been revoked. Yes, so yeah, we had a great discussion. We talked about the 12 research questions that were drafted before the meeting to kind of spark discussion, and reflected on what might be missing. You know, there was discussion around lifestyle approach, making sure we include young girls, who was, you know, a lot of the topics we discussed before, digging into social norm constructs, such as salient references, outcomes expectations, of course, including providers who are at the front of interacting with clients. But our discussion primarily focused for the latter part on how we can better link each of these research questions, or map, if you will, each of the research questions to the broader MH issues that we've been discussing throughout the conference. Specifically, how can we frame these questions into the broader environmental support from MH, and thinking about it from that angle. So trying to you really think about how the menstrual health part into the contraceptive element, and the link between the two, because there's a lot both sides have to offer and consider. Thanks.
Thank you, Holly, so much, and really salient points. Great, now we're going to move to the biomedical research and contraceptive R&D groups. So Rebecca and Kavita, could one of you do a quick report out?
Okay, hi, this is Kavita. I'll go ahead. We talked about, we had several questions to address, and one of the things that we talked about was that we need improved measurement and collection of biological data. And so different studies that are collecting information either on contraceptive-induced medical changes or on biological data should try to use the same tools, same types of measurement to help address some of the research challenges that we talked about earlier. And also that we definitely need more understanding of the biological changes that underlie some of these menstrual and bleeding changes that happen. We talked about how it's important to consider contraceptive-induced medical changes during all phases of contraceptive research, development, and introduction. And one of the main things that we realize we still don't know is, how different women will react to different methods. And Diana had brought that point up with her, the figure that she showed. We really don't know how to predict. And so what can we do to help us figure out how to predict how women might react? Should we focus on pharmacogenomics? Should we look at things like the microbiome? And how do we look at those things and when without facing sort of a chicken and egg problem? We also talked about how a few studies have shown that a woman's baseline bleeding pattern may predict how she reacts to contraceptives in terms of bleeding, and should we collect better baseline data? One other area that we assessed is that women who have bleeding disorders, for example, von Willebrand's disease or other common bleeding disorders, are often excluded from these trials. And so should they be included in these trials when we're trying to collect very clean data? And also, how do we figure out what methods are best for those women? We talked a little bit about focusing on prevention rather than treatment, and focusing on treatment to induce amenorrhea, as Lenita had suggested. And how, when we look at treatments, how can we learn from other fields, such as breast cancer prevention, for example? And I think I've used up my minute there.
Thank you, Kavita. That was great, though. Really interesting points. Wow. Okay, and also I'll say probably Rebecca Callahan did not share with her group that today is her birthday, so happy birthday, Rebecca. And now we will move to Lenita and Lizzie. Lenita, do you want to share a report out?
Just briefly, we spent a lot of time, a lot of what Kavita mentioned were things that we covered as well. We began by talking about the learning and what we don't know about the precise mechanisms of endometrial bleeding changes, and also the question of, are there better ways to assess, and what are the best ways of assessing endometrial changes? We talked about how you can gather that information, but we did end up spending a lot of our time talking about how one might use big data to and whether we really need to know the mechanisms, in advance of. I mean, it's a nice to know and it's an important to know, but can we use big data to identify phenotypes that might help counseling women and better understanding patterns? And so what does that mean? There are some data sets that could be used and that are already where there's some work going, but are there other things that we could contribute to begin to expand a data collection platform that could turn into big data that would look at things like lifestyle or environmental changes or other things that could then better inform the specific CIMCs that we're interested in. So I think
Thank you, Lenita. Yeah, that issue of big data is so interesting. Great. So we're going to move into the two groups that focused on service delivery guidelines, which sort of focused on what we might be able to do in the short and near term around providing guidance to programs and policies. We had two groups on that, and I co-facilitated one. I'm going to ask my colleague Jen Gassner to report out for our group. Jen, are you there?
Yeah, sure. So our group, we talked actually a bit about a pilot that MSI is planning for next year, looking at how we can integrate more menstrual health programming into family planning service delivery. And so we will be looking at integrating a bigger education component in terms of both community education and I hope some stigma reduction, but also integrating it into the group education we do when we do outreach services in rural areas to help kind of introduce contraception with the basics on menstruation, so that the link between the two and therefore the understanding of CIMCs can be a little bit clearer up front. And then linked with that, looking at introducing the provision of reusable products as part of a package they would receive when they get a contraceptive, so that it will help them with managing CIMCs, and then looking, of course, with that at what impact that may have on satisfaction, on, we hope, discontinuation and reducing it, but also looking at whether that knowing that information and knowing that there might be help in managing it might have any impact on the profile of a person who may be visiting the services or even the methods they may choose. So we talked a little bit about that, some of the difficulties that will be associated with that in terms of context, in terms of cost, which is a big one, you know, and that reusable products are still a challenge in terms of stigma and washing and drying. And, you know, just that there still isn't a lot of interest in funding that type of initiative. It is perhaps a bit more reactive, but, you know, that's where we are now. And so, yeah, I think that's where we got to, Kate.
Thanks. Yeah, that's
just talking
great.
through that. Yeah.
Great, thank you. And just a request to Irina and the last few presenters to go quick because we're running out of time. Irina, do you want to debrief on your group?
Yes, I'm unmuted.
You got it. We got you.
So we talked about remembering that there is already vast experience in these two areas exist, and incorporating these experiences into whatever service delivery guidelines will be developed is important, and also importance of having the guidelines adapted on or adopted on national level, and policies goes with it accordingly, otherwise it won't be implemented on the ground. The importance of promoting tools for providers that help them to incorporate counseling about menstrual changes into their interactions with clients, efforts to make supplies available, sanitary supplies available for free, the same way as family planning methods are available for free in public programs, and some good examples were given of successful interventions at this level. Then strengthening referral mechanism between two programs, but also educating providers about menstrual disorders so they know when to refer to actually a specialist, and better guidelines to menstrual disorders in general. And also consider how menstrual health can be an entry point for other services, including family planning.
Great, thank you, Irina. That's great. So then we had two groups on considerations for special populations. Trinity and Helen, could one of you give a quick report out?
Yep, this is Trinity. So our group had some fodder to begin our discussion. We were presented with several groups that are already potentially special populations. They include refugees, people living with HIV, people who are postpartum, people who are LGBTQ, and people with disabilities. And so we brainstormed some additional groups, including female sex workers, adolescents, survivors of domestic violence, as well as those who have undergone female genital cutting or female genital mutilation. And what we really focused on was the fact that we likely do not have sufficient data or information about these groups' lived experiences with preferences for attitudes towards CIMCs. And so that a basic research question is just that for these different groups. We also talked about other groups who are likely influential in either those special populations experiences and perspectives, or who can reach them with information and access. And so the importance of providers having adequate information and being equipped to reach out to these groups, and providers, not just our traditional providers, but groups like doulas. So we had a doula representative in our group, as well as partners, including male partners, and really thinking through how we can best reach these groups with information and what might be special channels that are required to reach them. And we talked a little bit about digital and whether that may be an opportunity, but also may be a barrier. And so again, a research question about having more data about the most appropriate channels to reach these people. And then finally, we talked about some specific groups who perhaps represent or engage with these special populations who we'd like to include in the movement. This movement, today's movement.
Thank you, Trinity. That's great. Good list of additional groups. Donna or Katie?
Hey, thank you. So an additional group that we talked about were people in the military. Given that many countries do have requirements for military participation, that we could probably potentially reach additional groups there. We had an interesting discussion about the importance of ensuring that our identification of the group is actually how people identify themselves, right? So not to make, not to come at it with a prejudged opinion about who is in a group, and the importance of knowing the person affiliates with that group. I think, like Trinity said, the need for information about some of these groups is obviously very apparent, and that we should be getting, if we want to address the needs of these groups, we need specific data about them. We had a pretty rich discussion about postpartum women in particular, and how some of the work that the POP Council is taking forward on that group, but basically that they're unique in many ways in that their return fertility can actually come back before their menses. And so really thinking about ways we can better serve that group of women who are postpartum. And I think we also talked about, I'm trying to think, I don't want to repeat what Trinity said. I think
we're also at time.
Pardon?
We're just at time. So
okay, we're just at time. Okay, sorry. Okay, sorry, my group, if I didn't represent you. Okay, we're just at time. Okay.
Thank you, Donna. That was perfect. So maybe we can go to the next slide, because if we finish on time, that'll be a miracle. Tabitha, can I hand it to you for a few closing words? And again, just thanks to all the breakout groups. What a rich discussion. So Tabitha, do you want to close us out?
I will. Can you hear me?
Yep, we got you.
Awesome. Okay. So, wow, this has been a real whirlwind 2 days. We've covered a lot. So, again, I'm Tabitha Scriptipatana. I'm actually, I'm an aide. I'm the AOR for the Envision FP project, which I failed to mention yesterday. So there's been a lot covered today. I think we've done a good job enhancing connections between the family planning and the menstrual health fields, but realize that this meeting is certainly not the end all be all. We do need to have a continued meaningful engagement. Figuring out a coordinated platform will be really important for that. So I'm just going to end. I want to give a big thank you to all the presenters and technical contributors, and a big shout out to the folks who made this meeting happen, including Kate Rademacher, Amelia McKenzie, Emily Hopez, Katie Williams, and Audrey Fratis. We certainly couldn't have had this meeting without your efforts. It was great. And a big thank you to all the participants for your time and meaningful engagement. So have a great day, everybody.
Thank you, Tabitha. Can we just advance to the last slide? Just want to thank everyone again for your participation. The slides from this meeting and the recordings will be available online, including the written Q&A that we've mentioned. We ask that you take just a few minutes to complete the evaluation. Emily's posted the URL in the link. Also, just a reminder that we shared the video today and ask you to share that with your channels. Finally, as Tabitha said, we hope that this is just the launch of many more discussions, and look forward to engaging many of you in those plans and discussions moving forward. So thank you for your time and your contributions and your energy, and look forward to advancing this important topic in the future. Have a great day, and thanks again.